Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. I can't thank you guys all enough for support of this podcast. You can continue to support it through meded101.com/store. If you need some study materials or you're looking for a book, looking for more education on pharmacology in general, I've got all the links to resources there. Definitely overwhelmed by the amount of support, and that support directly goes to helping me keep this podcast going and alive to help benefit others down the road, whether that be new students or new healthcare professionals. So greatly appreciate that. With that said, let's get into the drugs of the day today. We are continuing on with the top 200 list. Going to pick up on drug number 46. And that is Tizanidine. Brand name of this medication is Zanaflex. This is a skeletal muscle relaxant, or sometimes referred to as an antispasmodic agent, obviously for muscle spasms and those type of symptoms. Really a symptomatic treatment that I see occasionally used. Mechanistically, it's what's called a central acting alpha-2 agonist, and that ultimately helps reduce that muscle spasticity. With that said, if you think about this medication, it has a similar mechanism of action to clonidine, or at least overlapping in some ways. So what that means as far as a side effect profile is, if you can remember what some of the side effects of clonidine are, you're probably going to remember some potential adverse effects of Tizanidine as well. So it's probably a good guess with any skeletal muscle relaxant that it can be sedating. So that can certainly happen. It can increase risk for CNS changes and confusion. Particularly, this is a little higher risk in my patient population. The older we get, the more and more likely we are to experience that. And then if you think about what clonidine is sometimes used for, it's used to bring down blood pressure. And Tizanidine, maybe to a lesser extent, but again, kind of a dose-dependent adverse effect. Higher the dose, maybe the more likely you're going to run into some orthostasis and some lower blood pressure and fall risk issues as well there. From a drug interaction standpoint, one point of emphasis here is CYP1A2. So this drug is broken down by CYP1A2. So interactions with ciprofloxacin, fairly commonly used antibiotic, as well as fluvoxamine, which is an SSRI. So a couple drug interactions there I wanted to specifically point out via the CYP enzymes. All right, next medication is Risperidone. Brand name is Risperidone. This is a second-generation antipsychotic. So it binds to dopamine 2 receptors, which helps regulate the activity of dopamine in the mesolimbic pathway. So the easiest way I remember dopamine and that interplay in the brain, too much dopamine, and we can induce symptoms of schizophrenia and psychosis. Too little dopamine, and we can create movement disorders. Okay, so that's a really, really important kind of yin and yang homeostasis thing to remember with dopamine and the interplay between Parkinson's and psychiatric symptoms. It can definitely help you out on your board exams, pharmacology exams, as well as in clinical practice, if you just remember that interplay a little bit. So as you could expect, thinking about the adverse effect profile, extrapyramidal symptoms, movement disorder symptoms can be an adverse effect of risperidone. Now, it's generally not as potent or as problematic as some of the first-generation antipsychotics, like haloperidol, for example. But again, this is dose-dependent. A high dose of risperidone certainly will be a lot more likely to cause some of these extrapyramidal symptoms compared to a lower dose. So Pay attention to that, obviously, as we escalate dosages. Other adverse effects to think about. So we've got sedation, QTc prolongation risk. Remember that antipsychotics can cause metabolic syndrome, so that's something we may monitor for there. Hyperprolactinemia is definitely a risk with antipsychotics as well. The EPS symptoms I alluded to already. Fall risk can happen with that as well as orthostasis risk. Very rarely, it can cause neuroleptic malignant syndrome, which can result in some muscle changes as well as an increase in body temperature, somewhat similar to serotonin syndrome in some of the symptoms there. And then there is a boxed warning for the increased risk of death when we use this medication to treat dementia-related behaviors in some of our elderly patients. So good boxed warning there to remember that certainly you could be tested on in board exams with antipsychotics. With risperidone specifically, maybe comparing it to some of the other second-generation antipsychotics, it's probably kind of moderate to high on the EPS, those movement-type adverse effects, compared to other second-generation antipsychotics. And it's also high on the hyperprolactinemia risk. It can cause that a little bit more so than some of the other second-generation antipsychotics. Monitoring parameters, obviously we're going to look out for some of the side effects, any changes in movements and that type of thing. From a lab perspective, you may monitor for that metabolic syndrome risk. Think about lipids, A1C, blood glucose, things like that. And then one last thing wanted to mention was different dosage forms. Risperidone's got a bunch, or risperidone's got a bunch, whether that be oral solution or it's got some long-acting injectable formulations. So we do have a good variety there to kind of meet our patients' needs. And in schizophrenia and many mental health disorders, patient adherence is very, very critical, and it's very, very difficult as adherence rates aren't that good, particularly in schizophrenia and bipolar disorder and things like that. So definitely a big challenge there, and some of those dosage forms can sometimes allow us to improve that adherence a little bit. All right, moving on, we've got number 48, and that is Ramipril. Brand name of this medication is Altase. And if you remember your endings, so we've got Ramipril, P-R-I-L, that ending is going to indicate to you that this is an ACE inhibitor. So mechanistically, it inhibits angiotensin-converting enzyme, which ultimately results in less angiotensin II. And if you remember from physiology, angiotensin II is a potent vasoconstrictor. Adverse effect profile. This is definitely going to be important. If you ever have a patient with a dry cough, be sure to look at their med list and make sure that they're not on an ACE inhibitor like Ramipril. Definitely can cause a kind of dry type chronic cough. Hyperkalemia, we're going to be monitoring potassium levels. And, certainly this can be exacerbated by other medications, whether it's, a potassium-sparing diuretic, potassium supplements, even an antibiotic like sulfamethoxazole trimethoprim can increase potassium levels. So pay attention to that, and that's definitely a lab you're going to want to be monitoring, as well as kidney function too. It can cause some changes in renal function and potentially worsen that as well. Rare adverse effect I wanted to mention was angioedema, so kind of swelling of the lips and throat, and it can stop or block breathing if that angioedema is severe enough and swells up kind of in the airways coming from the lungs there. So that's an important one to think about. There's lots of compelling indications for ACE inhibitors in addition to it being an antihypertensive. can be beneficial in, CKD, diabetes, stroke, CHF, heart attack, as far as added benefits in some of those disease states there. With monitoring, I wanted to mention maybe a little bit, deeper nugget here. But historically, if you see a 30% increase in creatinine, so that's your measure of kidney function, if you see a 30% increase in creatinine levels or more, that's likely indicative that that ACE inhibitor is potentially worsening renal function, and that it should be stopped potentially. So keep tabs on that. And again, that's why we monitor renal function with ACE inhibitors and with Ramipril here. Lastly, I think it probably is pretty obvious, but all blood pressure lowering medications can drop it too far. So pay attention to orthostasis and fall risk in patients. All right, moving on to number 49, we've got Pravastatin. Brand name is Pravachol. Mechanistically, as you could probably guess by the ending, Pravastatin, it is a statin medication used in the management of cholesterol. So mechanistically, it inhibits HMG-CoA reductase, which is ultimately responsible for the rate-limiting step in the production of cholesterol. Adverse effects with all statins, probably the biggest one you're going to be tested on, need to pay attention to in practice is myopathy, so kind of all over muscle pain and achiness. Sometimes that can slide under the radar. I've seen that in practice with statins, where gets diagnosed as kind of generalized osteoarthritis, or the patient maybe doesn't describe the pain that well, and maybe they've been on a statin for years, but maybe we started a medication that increased concentrations and caused a drug interaction and increased the risk for myopathy there. So pay attention to that. Ultimately, in severe situations, it can lead to rhabdomyolysis. That's going to be noted by an elevated CPK, and ultimately it can increase the risk for acute renal failure. So definitely pay attention if patients are reporting muscle pain, muscle soreness. We've got to get at that and figure out how severe it is. Maybe can we switch statins? Can we reduce the dose? Do we have to come off it altogether? That's definitely kind of a clinical judgment, something you need to figure out. CPK may be checked to kind of rule that out and figure out how severe of a situation this is. But I found in my experience, if patients get that muscle pain, muscle soreness, they generally are very reluctant to go on and try another statin. And in some cases, if it's not severe, we can certainly try it. Obviously, if you've got a patient that's had rhabdomyolysis on a statin, there we've got a little higher risk, and likely are probably not going to try another statin in most cases there. So. And there are some subtleties with statins. Some are lipophilic, some are hydrophilic, that may or may not, help in alleviating and reducing myopathy type symptoms. But again, in general, rhabdomyolysis is a very severe type situation that we need to pay attention to and not overlook. But again, very, very rare as well. The advantage, I guess, of Pravastatin, and maybe one disadvantage. So first, let's start with the disadvantage. It doesn't get as potent reduction in LDL as some of the high-intensity statins, like atorvastatin and rosuvastatin. So that's kind of a downside with it. Some clinicians anecdotally will say that they've noticed a little less myopathy with it, and thinking that maybe that's due because it's a hydrophilic statin compared to a lipophilic statin. The evidence on that is, there might be some out there, but that's something that clinicians sometimes try. If, patient starts atorvastatin, they couldn't tolerate it, they had some myopathy or other adverse effects, sometimes you might see Pravastatin at a lower dose utilized and tried to titrate up and see if and what they might tolerate there. So again, always depends upon the severity of the reaction, as well as what your patients are kind of willing to do and consider after you've educated them on the risks. Pravastatin does have a lower number of drug interactions compared to some of the other statins like simvastatin and atorvastatin more specifically there. So that's definitely a little bit of an advantage there too. All right, moving on, number 50, last drug I'm going to cover today. We've got Terazosin. So brand name is Hytrin, and this is a non-selective alpha blocker. Okay, so when we talk about selectivity of alpha blockers, usually we're talking about the urology system and the urinary system. So some of the selective alpha blockers are like tamsulosin. That's a great example, commonly used one, primarily used in BPH, for example. Now, the non-selective alpha blockers have, many years ago, have historically been used for lowering blood pressure and management of hypertension. Probably the only situation I really see these agents utilized for, like Terazosin, is BPH in combination with hypertension. Okay, so mechanistically, how does it work? It's an alpha blocker. So blocking those alpha receptors can cause smooth muscle relaxation, which ultimately leads to vasodilation. That's why it's beneficial, or can potentially reduce blood pressure, as well as opening of the ureter, which again, kind of opening up that passageway in BPH can kind of help ease the flow of urine out of the body there. They can work quickly to help relieve symptoms in BPH compared to, let's say, 5-alpha reductase inhibitors that take a long time to actually shrink the prostate. Terazosin can help certainly with that. So why don't we use these medications for blood pressure management? Why don't we use Terazosin for blood pressure management? It can cause some orthostasis, so significant orthostasis, and that's most apparent usually when starting or increasing the dose. So again, that's that dizziness when somebody stands up, for example. So really important to educate your patients about that they're likely to get dizzy when they change positions. They go from sitting to standing, particularly when starting this medication. Okay, so definitely important to remember that. One other kind of deeper nugget here, particularly in relation to the eye. Alpha blockers have been shown to increase the risk of floppy iris syndrome for those who are or have undergone eye operations. So really important to communicate with the optometrist, surgeon who's ever doing surgery on the eye, and have them recognize, okay, yes, this patient is taking an alpha blocker like Terazosin. So again, very important to have that great communication between healthcare professionals and make sure that we get them off the medication, or at least that the specialist doing the eye procedure is aware that they're taking this medication and some of the complications that can happen with that. All right, well, that's going to wrap up the podcast for today. Do me a huge favor, leave a rating and review on iTunes or wherever you're listening. Go to reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. It's a no-brainer to have. Great review if you're out in practice, or if you're studying, preparing for board exams or pharmacology classes in school. Great refresher. Some of the most important things that I've seen come up on some of those exams throughout my career, as well as in practice there. So simply an email will get you access to that at reallifepharmacology.com. Please look at meded101.com/store if there's a book there where you can help support the podcast or study materials, anything like that. We greatly appreciate that support. Help keep this podcast available and free for all to benefit from. If you got any comments, suggestions, feel free to reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn Eric Christensen, PharmD, BCPS, BCGP. Can't thank you guys enough for the support. We are at millions of downloads at this point in time, and it's a humbling thing, and I try to do my best to get you the best education that I possibly can based upon the experiences I've had and the time I've spent in learning pharmacology. So hopefully this is helpful for you. And with that, I'm going to let you go. Take care. Hope you have a great rest of your day.